This lecture will continue to talk about the surgical treatment for PAD, as well as also cover acute peripheral arterial occlusion. So we talked about what exactly the bypass surgery is, and we started going over some of the post-op concerns after this bypass surgery. And again, that we're bypassing that arterial occlusion. We've talked about the need to monitor for graft occlusion. Emergency thrombectomy, or the removal of the clot, which the surgeon may perform at the bedside, is the most common treatment for acute graft occlusions. Local intra-arterial thrombolytic or clot dissolving therapy with an agent such as TPA or an infusion of a platelet inhibitor such as abciximab may be used for acute graft occlusions. Other antiplatelet drugs may be used as alternatives. The healthcare provider considers these therapies when the surgical alternative carries high morbidity or mortality rates, or when surgery for this type of occlusion has traditionally yielded poor results. Closely assess the patient for manifestations of bleeding if thrombolytics are used. Graft or wound infections can be life-threatening. Use sterile technique when providing incisional care and observe for symptoms of infection. Assess the area for induration, arrhythmia, tenderness, warmth, edema, and drainage. Also, monitor for fever and leukocytosis, which is increased serum white blood cell count. Instruct patients on methods to promote vasodilation. Teach them to avoid raising their legs above the level of the heart unless venous stasis is also present. Encourage all patients to avoid smoking and to limit dietary fat intake. Remind them to drink plenty of fluids to prevent dehydration. Reassure patients that participation in prescribed exercise, nutrition therapy, and drug therapy, along with cessation of smoking, can limit further formation of atherosclerotic plaques. Patients with arterial compromise may need assistance with ADLs if activity is limited by pain. Please review Chart 36-3 on your own in regards to foot care for the patient with peripheral vascular disease. Although chronic PAD progresses slowly, the onset of acute arterial occlusions is sudden and dramatic. An embolus, a piece of clot that travels and lodges in a new area, is the most common cause of peripheral occlusions, although a local thrombus may be the cause. Occlusion may affect the upper extremities, but it is more common in the lower extremities. Emboli originating from the heart are the most common cause of acute arterial occlusions. Most patients with an embolic occlusion have had an acute MI and/or AFib within the previous weeks. Patients with an acute arterial occlusion describe severe pain below the level of the occlusion that occurs even at rest. The affected extremity is cool or cold, pulseless, and mottled. Small areas on the toes may be blackened or gangrenous due to lack of perfusion. Those with acute arterial insufficiency often present with the 6 P's of ischemia. The 6 P's of arterial insufficiency are pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, which is coolness. If the nurse notes signs of ischemia, the primary healthcare provider must initiate treatment promptly to avoid permanent damage or loss of extremity. Anticoagulant therapy with unfractionated heparin is usually the first intervention to prevent further clot formation. The patient may undergo an angiography. A surgical thrombectomy or embolectomy with local anesthesia may be performed to remove the occlusion. The healthcare provider makes a small incision, which is followed by an arteriotomy, which is a surgical opening into the artery. A catheter is inserted into the artery to retrieve the embolus. It may be necessary to close the artery with a synthetic or autologous, which is the patient's own blood vessel, patch graft. After an arterial thrombectomy, observe the affected extremity for improvement in color, temperature, and pulse every hour for the first 24 hours or according to the post-op surgical protocol. Monitor patients for manifestations of new thrombi or emboli, especially pulmonary emboli. chest pain, dyspnea, and acute confusion typically occur in patients with PE. Notify the healthcare provider or rapid response team immediately if these symptoms occur. Watch closely for complications caused by reperfusing the artery after thrombectomy or embolectomy, either of which include spasms and swelling of skeletal muscles. Swelling of the skeletal muscle can result in compartment syndrome, which occurs when tissue pressure within a confined body space becomes elevated and restricts blood flow. Monitor for increasing pain, swelling, and tenseness. Report any of these symptoms to the provider immediately. Fasciotomy, which is a surgical opening into the tissue, may be necessary to prevent further injury and save the limb. Catheter-directed intra-arterial thrombolytic therapy with fibrinolytics such as alteplase or TPA has emerged as an alternative to surgical treatment in selected settings. The tip of the catheter is embedded into the clot to directly deliver the thrombolytic infusion for 24 to 36 hours until the clot dissolves. During infusion, monitor the patient for complications such as bleeding and hemorrhagic stroke. Maintaining a normal blood pressure is essential in preventing a potential stroke. As the clot dissolves, the patient typically experiences severe pain due to reperfusion that requires PCA, or patient-controlled analgesia. When fibrinolytics are given, assess for signs of bleeding, bruising, or hematoma. For patients receiving any platelet inhibitor, monitor platelet counts for the first 3, 6, and 12 hours after the start of the infusion, or per agency protocol. If the platelet count decreases below 100,000, the infusion needs to be readjusted or discontinued. If any of these complications occur, notify the healthcare provider or rapid response team immediately.